So thank you for the opportunity to speak here. And again, I'd like to thank Dr. Meenakshi for the invitation and as well as a lot of the inputs and direction in creating this talk. We've completed bits and pieces of assessing the trainee at the workplace. We've even spoken about assessing the trainers. But I think as surgeons, we need to understand that our specialty and what we do essentially, a bulk of it is in the OR. And we have to be at least, have to be able to get our trainees to reach a certain level of comfort and competence in the most basic ophthalmic procedures before they graduate. And that is why we have this entire concept of the OSCAR, and I'll go over these points, which is the need to assess objectively. Because now say for example, this is a recurring diagram that you'll see in my talk. When we talk about optimizing resources, say for example in the OR, we are going to figure out who are the trainees who are going to operate for the day. We'll control the processes in terms of which senior resident will get which complicated case and which junior does the simple surgeries. We'll watch how they operate, give them the feedback, assess their results, and as they improve in their surgical skills, that will help us optimize resources even better, because now we can allot more complicated cases to those residents, etc. So at the heart of all of this remains patient safety. And this is why the moment we see a trainee who is operating, it's important to give them immediate feedback, because the moment we see them operate, we see them doing certain things which may or may not be right. It's important to give them immediate feedback, because recent memory or correction of recent actions have the highest retention. Now, you don't want to go and tell them, last week I had seen you operate the 3rd case out of a list of 5. In that you did that. You probably barely remember it, so that resident is not going to. And you have to give the good and the bad feedback, and always perhaps preface the bad feedback with a little bit of good feedback. You can sandwich it, because feedback is the cornerstone of this entire process. And I said this in the morning, and this is a line that I borrowed from Dr. Meenakshi's presentation, which is, we cannot expect someone to do exactly what we want unless we tell them exactly what we expect. So when we give this feedback, how is it going to actually matter to them? Because we need to know what is it that we have to convey to them. How we came to the level or our judgment that their competence was achieved or not achieved, explain that to them, and describe the process of how we reached there. If we tell them that this was a very good capsular excess, we need to tell them why we think it was a good capsular excess or why it was a bad capsular excess and why they need to improve on that. And how do we come to this? Dr. Kaushik said a very wonderful thing. Not all great clinicians may be great teachers, and not all great teachers may be great clinicians. So we tell them, we ask them, a trainer or a teacher, they may not be able to explain why a trainee is not performing well, and to help them is why we need a structured rubric, and that is where OSCAR comes in. So a rubric is essentially a guideline, and in this case it's an explicit set of criteria that we use to assess any particular surgery or performance. And these are the 3 pillars, the dimensions that are described in it, which means what are the steps that we are going to assess, the levels of competence or how well they are doing, which are graduated from a novice to an expert, how well they are doing that step, and descriptors. What is it that defines why they are a novice or an expert? And there are these rubrics for every different surgery now available. And I'm going to pull up the one that is most commonly used for cataract surgery, which is for phaco. So if you look at all of this, now let me just pull up the first 2 topics, draping and incision and paracentesis. So here, let me pull up the 3 dimensions. So now here, these are the steps of the procedure on our left side. These are the levels of graduation of how good or bad they are. You have the columns, which is novice, beginner, advanced beginner, competent, and what is it that makes them a novice? So the descriptors. So you've got all 3 parameters or all 3 tick boxes in this. And if you give this adequate granularity, which is right from the first step of draping right till the end, then you have given, you're able to understand and assess the trainee across every step and sub-step in that surgery. So a structured rubric gives you this advantage. And this is the ophthalmology surgical competency assessment rubric called the OSCAR, which is standardized and internationally validated on different surgeries. It's got different, it's got behavioral and skills-based rubric, which tells you if a surgeon is doing something right, what makes them go into which category. Also, when a surgeon is doing something wrong, why they are falling back into a beginner or a novice category. The single most important part of this rubric is it is objective, which means that interpersonal or inter-observer variability is less. It does not allow the surgeon to like or dislike or put a personal preference, because they are giving you a very clear criteria of how to judge and score the trainee. And also at the end of the day, especially if a trainer is assessing the trainee with the OSCAR rubric in their hands while they assess or observe, along with the surgical video, the paper or the feedback or the form that they fill up goes to the resident, and they can actually see where they fell behind and use that as self-learning or self-improvement tools. So the goals of OSCAR was precisely this, is to create reliable, reproducible, valid surgical skill assessment. And they basically, the stages of competence based on which the trainee is divided is the Dreyfus model, which is either a novice, a beginner, an advanced beginner. An expert is not something that we'd expect a trainee. Every trainee at the end of residency may not reach that stage. Well, some of us are still not experts in our own specialty or subspecialty. So this is the reason why we created the OSCAR and why it works. Now, to understand the role of the OSCAR is at the end of, I'm repeating myself and a lot of the other previous speakers, is to measure the results, to assess how they are improving, and to document how they were doing. And entirely, in some way, the OSCAR is also based on the TOE model, which is you grade or score the technique, you grade and score the outcomes, and also you observe the errors that the trainee makes. And all of these, along with their behavioral, cognitive behavior during the procedure, helps you score the trainee. There are OSCARs available for different cataract surgeries, for small incision cataract surgery, phaco, extra cap, strabismus, lateral tarsal strip, there's external DCR, there's anterior approach ptosis surgery, trabeculectomy, and panretinal photocoagulation. This is just a few of them. There are a few more as well, all of which are now available on the OF website. Some of them have transitioned from the ICO to the OF, so it's also on the ICO website if you're interested. And finally, how do you effectively use these? So now we know, why do we need to assess objectively, what are we going to do with the OSCAR, and why did we come up with the OSCAR, and now we need to see. Now the OSCAR, apart from those steps and the gradation of the trainee, there is something additionally in this called global indices. Global indices is a very a behavioral assessment, and it's generic terms, I'd say, but at the same time specific in their outcomes. Now, if you look at global indices, this is what it is. So you've got things like maintaining hemostasis, tissue handling, knowledge of instruments, technique of holding suture. So a trainee may actually be able to get one single suture right, but in spite of holding the needle in a wrong way. So we are not just grading the actual act of taking a suture or how the suture came out, but how the trainee performed in holding the suture, passing it through the sclera or the cornea, and how they tied the knots. So the trainer is also expected to assess global indices, which goes as a part of the OSCAR. So I'm going to do a short exercise there. I'll run this video. This is just one step of making an entry into the eye for a phaco, and we'll try to see what the audience feels or where they would grade this trainee. You can see he's a little tentative, so he's definitely a trainee. This is courtesy one of the videos from Dr. Uday Devgan's huge cache of surgery videos. All right, so he or she has made a decent corneal entry. Now, we are not expected to know the entire table by heart in our head. So you can actually carry it on your iPad if you are Pranesh, or on a piece of paper if you are one of us. But the point is to have it ready with you. And there's absolutely no shame in having that while you're assessing, because these are things, you're not going to, it has got so many steps on so many levels. It may not actually be feasible to go back and to think of how the surgeon was doing the surgery and then retrospectively grade it. So have it next to you. So now this is your incision and paracentesis. Let's just look at incision. How many of you all think this was score 2 for a novice? A show of hands. How about a beginner? Score 3. Advanced beginner. 4. The incision was well placed. Okay, we don't know if it was non-leaking yet. Or a competent surgeon. So none of you are assessing. What would you assess? 4 or 3? 4? All right. So let us look at the video again, and based off of what was actually, so this is actually a surgical video which was submitted by a trainee called My First Clear Corneal Phaco. And based on the commentary that Ujay Devgan has given, and also the point markings that he did later on, we're looking at a couple of things. Now look at how the trainee is grasping the conjunctiva and what happens at that site. There's a subconjunctival hemorrhage. Now here the trainee is a little tentative, makes an initial incision, then again goes back in. Now it's traveling too shallow, hugging the roof almost, and makes an abrupt indent downwards, creating that dimple. And there's a very abrupt jerk-like entry into it. What the trainees actually ended up creating is something like this, which is known as the chevron appearance. And what that happens when you have a shallow roof to your tunnel, a sudden abrupt cliff-like entry, which is suggestive of a very poor form. So this would actually push you back into probably a beginner or a novice. And again, you need to, when you look at the global indices, you would end up saying that patient was not, the tissue handling could have been a little better. So let's try scoring this rhexis now. Same surgeon, same case. You can see how much that subconscious hemorrhage is now increased. So you're creating the initial incision. The trainee is able to grasp well and re-grasp at the right side. Now, the trainee could have grasped it closer to the uncut edge, struggles a little bit, and now when he decides to grasp a little closer, he's able to do that and has managed to create a capsular rhexis. Now again, it's not at the tip of our fingers. We go back and look at it. Capsular rhexis, commencement and formation. So first thing is the size and position are adequate for the kind of nucleus. Inadequate, all right. So that would then put the trainee directly in the novice. Barely adequate, so it has multiple steps, multiple parameters by which we can grade. And you're right, let's look at the actual rhexis, how it went. So this is not a well-centered or an adequate nucleus for adequate rhexis for this nucleus. So that is why you would be able to grade it very objectively using the descriptive parameters in them. Excuse me. So at the end of the day, the Oscars are here to help us make objective assessments, which are reproducible assessments. It helps the assessor with specific examples of what to use as a guideline while scoring or assessing trainees. Tells the student what is expected of him at that level of training. Helps identify specific areas where they need special guidance or improvement. And it gives us the opportunity to provide a structured feedback, not to, for the trainer to provide a feedback in a structured form to the trainee, because sometimes the trainee may feel, oh, that the academic dean doesn't like me, or this consultant doesn't like me. Well, at the end of the day, it's not personal preference or not. You have a structured feedback that tells you that, no, we are upset at you because you need to improve, and not because we don't like you or dislike you. So it makes gives you method to the madness, if I may say it. So thank you, and I think we can move to the next talk.
How many of you here have incorporated the Oscars into your... oh, that's a great, good show of hands. Yeah. Thank you.
So just a quick thing. So the Oscars are actually now expanded even into simulation. So there's a validated tool called the Sim-Oscar, which allows you to assess the performance of a trainee on a surgical simulator, and different simulators. You have the Fidelis, you have the IC, and the Help Me See simulators. There are papers where all three of them have validated the Sim-Oscar, which was, I think, initially formulated by Will Dean and his colleagues. Yeah.
Yeah. How often do you incorporate the Oscar?
We did that for the first 20 cases. And then is when at that point, then you actually see a plateauing. And that tells you. But the first 10 cases are crucial in helping you identify where is it that this particular trainee is growing up. Especially, so what we saw was cases 1 to 5 were the SICS tunnel depth. Premature entry was the most common. 7 to 12 was when they would struggle with a rhexis. And I think case 22, 23 is where they were a little more consistent in their scores.
I think you could also identify the steps that they struggle with consistently. And you don't have to, you may be a busy rotating supervising surgeon. You may not have time to do an entire Oscar. So you could just come in for those steps to see if those have improved.
As part of my advanced course in medical education, I did a project on Oscars. So where we made them record their own videos, and then we asked them to score themselves, and the faculty who was observing also scored. So we had a comparison of the results between the second years as well as the third years. So in that we have two aspects. Not only the faculty scored, but they themselves saw the videos and they also gave the scores probably. And then one more feedback was there after the surgery was over when they scored. So we had a comparison like what I scored and what the resident scored. So that also we actually...
So what was the...
there was actually what happened was between second and third years. The third years, obviously, because of number of cases by the final year, they would have done more when compared to the second year. So that was, their scoring was good. I mean, their feedback for themselves. And not much of a difference between the faculty and the student feedback.
Okay.
But in the second years, obviously the difference between the second and the third year was significant because of the number of cases what they did, and the faculty who scored also. That the same kind of a difference, the difference between faculty and the student scoring was much more in
So the agreement was greater for final years and lesser for second years amongst self-reported scoring and faculty scoring. So that's very interesting. Trainees felt they were not as good as the faculty thought they were, or did the trainees rate themselves higher?
The scoring was much more, I mean, it was similar. The faculty, the particular step, whatever the trainees thought that probably a 2 or a 3, even the faculty had given the same score. Okay. More or less in some steps, probably hydrodissection or tissue handling, the global indices where the trainees thought that they managed the tissue very well, but that was not the case from the faculty. That was the major difference.